no matter where the patient goes. It's possible that the patient says, my priest is my caregiver. That's where I want to go. I mean, I can well imagine my late grandmother, that's the only person she would trust, nobody else. How can we make sure that our systems respond to that? So that if she says, this is my primary caregiver, somebody may say the pharmacist, the local pharmacist, has been in the community for decades. That's the person I trust. Don't bring some newfangled youngster from somewhere. I don't know who that person is, right? How can the technology kind of gather around the patient and say, you can choose who you want. We will make sure that you get the same seamless experience that we want to give you as a primary care, but now you'll get it through. And then that person will then be empowered to say, I can do X things, but here are other people, the health worker, the pharmacy, the somebody else that I can draw. But that sounds pretty powerful to me as a design principle.
You know, I totally agree. It's less about choosing a specific channel as the anchor, and more about this ether that we're talking about, and building it, and then having that really support the various touch points that we all have in our lives that support us, and in our journey as people and our health. And sometimes it might be a religious institution, sometimes it might be your your spouse, sometimes it might be the healthcare worker. But I do think that like technology has that amazing potential in maybe the not so distant future to bring some of that together, so that's less about these vertical approaches that are focused on one solution, but we can build on each other's.
We often forget that poor people have agency as well, and must have agency, right? They do get to choose where they're comfortable, where they want to go for care. And because we don't acknowledge that, we end up investing billions in building public infrastructure, only to see that people are still showing up at the neighborhood pharmacy or to the community health worker, rather than going to the community clinic that was set up for them, right? So I think that's absolutely fundamental as we design health systems going forward. Thinking of people as having agency is absolutely crucial. There's a role here for everyone, starting with regulators. I think deciding on those interoperable standards, building those road networks, and so eloquently put it. I think that's absolutely crucial, and regulators need to play a role in ensuring that happens, and that individual organizations actually comply with those regulations. I think there's a real role for donors here, because if we continue to fund in disease silos or channel silos, we'll end up seeing more and more fragmentation and not more integration. So there needs to be more donors that come in and say, we want to integrate these different siloed pieces. There is a role for researchers. I think there's real importance in studying patient journeys and pathways as they exist. I think one of the reasons why pharmacies or families are not visible in the care system is because we don't study people's journeys enough, which would tell us where people are going for care and who do they really trust, right? So really understanding those journeys and understanding the trust networks is a real role for researchers. And I think finally a role for technologists here in designing those algorithms, in designing those kind of idealized pathways using algorithms. I think there's real potential for innovation there. And I'm really excited to see what comes up in the next couple of years as LLMs mature and people build agents on top of them. So I'll stop there.
No, that's a wonderful summarization, Rubayat. One thing that reminded me of the work Shahed, your team has done, which is, in a way, bringing another tool into the fold, which is this WhatsApp type communication with patients, with caregivers, so that you're not learning a new tool, going on to a new app, downloading something else. What you're saying is, you're used to working with this. Why don't we design behind you so that you can continue doing what you're comfortable doing? But
yeah, maybe just adding to that, the ethos is just make something that people want, and don't reinvent the wheel. Build on the infrastructure that exists. There's so much out there, and I think there's a real opportunity for again, rather than creating another tool, another thing that lives on its own and complicates the system to build, build on what exists and what people are already doing and using. As someone who is not at all a technologist, I can't speak as smartly as all of you did about the way in which we can think about better digital connectedness in the future. As a practitioner who is committed to trying to not build something that does not need to be built, and not reinventing the wheel, it is hard. It is hard, and I think I really look forward to that road that you're talking about, so that we can all be on a journey together. Really thinking about that as a principle is making sure that you're not reinventing the wheel, tapping into systems that already exist, working together, so that more silos aren't created, and then looking out for that North Star of fire or whatever whatever it might be.
I do think we have a real opportunity with the growing momentum around FHIR. That's fast healthcare interoperability resources, to really think about what the future might look like if we all were speaking the same language. Maybe that could actually reduce some of those barriers that we see and some of those silos. If we had kind of a set standard, at least we're all going in the same direction. So our data that we're leveraging with community health workers and health systems could talk to the pharmacy data that Rubayat that you were talking about, and then talk to the caregiver node as well. So just wanted to throw that out there.
So how do we bring this together? What does your instinct tell you as you think about the future? Is it the family? Is it the health worker? Is it who that brings all of this together? Or is it somehow what Rubayat is saying, what I'm saying, the larger ether, as it were, the internet space that is bringing it all together?
I mean, one thing that's coming out as a theme here, I think, is patient autonomy or choice. And ultimately, some patients will have family members and caregivers. Some patients will be lonely and isolated. Some patients will want to go to the public system, especially if you're in sub-Saharan Africa, where that is the majority of healthcare delivery. Other patients will go to the private system. Others will want to go to the pharmacy, and some will go to the faith-based segment or their place of worship as a node of trust. And the key here, I think, is to build technology that doesn't limit the patient choice, but at the same time can provide some direction based on all of the research and clinical knowledge that we've amassed historically as humans, I suppose. And that's perhaps where the large language models come in into the picture. I think there's some concerns always around, what corpus of data those models are trained on and how do we expand that so we're kind of looking inclusively. But I do think there's huge potential for AI and data to play a role there. I do think actually getting that data in one format is foundational, which is why I'll go back to the FHIR standard. And I think what you were talking about as well, Nachiket, around how do we create like the DPG, DPI infrastructure that's required. But yeah, I think I'll just maybe end with bringing it back to the patient, building respectful technologies, leveraging emerging technologies, but ultimately allowing the patient to navigate through the system in a way that makes sense, and excited to continue this